An acromioclavicular sprain is often called a separated shoulder. The mechanism of injury can be both chronic or acute. In a chronic mechanism, this may be due to overdoing it on the bench press, for example, or it can be simply due to scapular dyskinesis. An acute injury can be both indirect or direct. The indirect mechanism will be due to a longitudinal axial loading, falling on an outstretched hand, for example, or foosh for short. The direct mechanism is falling or landing on the superior or the lateral shoulder, oftentimes referred to as a shoulder pointer injury. AC sprains are classified based on the extent of ligamentous damage, the degree of instability, and the direction the clavicle displaces relative to the acromion and the coracoid process. As athletic trainers, very often we will use the grade 1 through 3 to grade the injury, but physicians will look at different types, type 1 through 6, and we will review all of these. In a type 1 AC sprain, we consider this a grade 1 injury. In this case, it will be graded type 1 because it has 0 to 25% elevation of the clavicle on the acromion, and the injury is to the AC ligament. In a type 2, we will grade as a grade 2 injury. It is 26 to 50% elevation of the clavicle on the acromion, and the injury is to the AC ligament and to the coracoclavicular ligament. In a type 3, we will begin to see a piano key deformity or a step-off deformity. This is considered a grade 3 injury, possibly a grade 2. There will be a 51 to a 100% elevation of the clavicle on the acromion, and again, an injury to the AC ligament and the CC ligament. In a type 4, again, we will call a grade 3, the clavicle displaces posterior to the acromion. In a type 5, you will see something called tenting, and oftentimes we will consider that a super type 3. And then type 6, the clavicle will move anterior and inferior to the coracoid process. Signs and symptoms that you will note include pain localized to the AC joint and the coracoclavicular ligament, a positive piano key sign, swelling, ecchymosis in the area. The patient will be dysfunctional with shoulder abduction and flexion, so they are going to find that it's difficult to perform a bench press, a push-up, or overhand throw. Long-term AC joint dysfunction leads to scapular dyskinesis and shoulder impingement and rotator cuff pathology. During range of motion testing, there will be reduced active and passive range of motion for shoulder abduction and flexion. There are many special tests that can be performed. The AC shear or compression test is simply cupping the hands on either side of the shoulder and squeezing. The piano key will be looking for that lift-off sign. In AC joint distraction test, the patient will sit with the involved arm relaxed at the side. The elbow is generally flexed to 90 degrees. As an examiner, you simply apply a gentle downward pressure on the arm, noting any movement at the AC joint. You will have your hand placed over the involved AC joint so that you can also palpate that joint motion. The active compression test is also known as O'Brien's test. In this test, the patient will flex their shoulder to 90 degrees with internal rotation, with the shoulder adducted approximately 10 degrees. The patient will resist your downward force and then perform the same test with the arm supinated. In the case of an AC separation or an AC sprain, we are looking for pain at the AC joint only. Neurovascularly, review the brachial plexus. An X-ray will be performed to rule out fracture in the area and will also be used to diagnose the injury type or severity. In the case of treatment, both type 1 and 2 are going to be conservative, and usually the patient is placed in a sling. Type 3, 4, 5, and 6 are going to require surgical repair. Recovery-wise, type 1 sprains generally will recover in 7 to 14 days. A type 2 will take about 4 weeks, and a type 3 will take from 6 to 8 weeks. Long-term wise, again, AC joint dysfunction is going to lead to scapular dyskinesis and shoulder impingement and rotator cuff pathology. So this is one injury that we want to make sure is healed properly before the person is allowed to return to full use of the shoulder.